So, hello everyone, very good evening to all. So, welcome to the second session of the second series of Navigate Medico CME program. So, today I welcome I would like to invite Umesh Kapil sir. Professor Umesh Kapil is Secretary of National Academy of Medical Sciences. I invite sir to give a welcome address to the participant and the speaker.
Good evening and namaskar to all of you. My most sincere welcome to all the participants. My humble submission is that if you like this series of lectures, please disseminate amongst your colleagues who are interested in the field of epidemiology and research. Because epidemiology and the physiology, they are two mother of all sciences, all medical sciences, all subjects. Whether it be clinical practice or surgery or medicine or anything. We use the epidemiological methods knowingly or unknowingly. That's the bottom line of the epidemiology. Now, coming back to this series of lectures, I would like to say that today we are going to discuss the randomized controlled trials and what are the methodological issues, what are the reporting guidelines. Unfortunately, from our country, if you look at the PubMed, very few RCTs are being conducted in the country, because it requires a lot of efforts, a lot of dedication, commitment for doing the RCTs. But if you look at the grade of evidence, if you look at the different grades, the RCT is the second most important or highest grade of evidence. And then higher to that is systematic review, which is a review of all RCTs conducted in a particular field. So RCTs are very, very important in the field of epidemiology. We must understand that RCT is one of the most important tools of conducting research, whether it is community research, operational research, clinical research. And we have with us Dr. Manya, who has been an outstanding research scientist, a senior faculty member from ILBS. My only humble submission to you is, please ask as many questions as possible to Dr. Manya, and I'm sure that she will be able to respond, because we have kept 1 hour specifically for the question-answer sessions. So, Dr. Navnika, Dr. Sarthak, and dear Siddharth Sood, please ask as many questions as possible, so that you must grill her. That's something. And I tell you one thing, it's not that when you ask question, we also get a learning opportunity. It's not the one-way communication. If we don't know anything, we go back and look into the literature, try to clarify our doubts. So please ask as many questions as possible. And we are very grateful to all of you for joining us. And please disseminate the information about the Navigate program to all your colleagues who are interested in the field of epidemiology. Thank you very much. Over to you, Dr. Jasmine.
Thank you, sir. So now I welcome Dr. Manya Prasad. Dr. Manya Prasad is a faculty at Institute of Liver and Biliary Sciences, New Delhi, in the Department of Clinical Research and Epidemiology. She has a specific interest in clinical epidemiology, guideline development, medical research, systematic reviews, and meta-analysis. She has around 3,000 citations, and she had done a lot of work in the field of research. She has 43 international articles in Medline indexed journals. She has facilitated many workshops on research methodology, evidence-based medicine, and great tools. She was given gold. She was awarded gold medal in MD final exam. She is also a recipient of International Epidemiology Association Fellowship. So now I would like to welcome Dr. Manya Prasad to start the session. Over to you, Dr. Manya.
Thank you so much, Dr. Jaswant, for that very kind introduction. And I'm delighted to be back for the second session in this series. And once again, I remind the participants here that this will work best if there's maximum interaction. And I'm so grateful to everybody who participated in the interactive sessions and who interrupted to ask questions and to make suggestions. And I hope that trend continues for all the sessions. So without much ado, I think I'll begin the session for today. And we're going to be discussing an exquisite design in epidemiology, and that's a randomized control trial. And what I will take you through in this session is methodological issues. So you will see, at least I will try to make you realize that there are many safeguards in RCT, methodologically speaking, that ensure that the validity of the RCT is maintained. And so I'll be talking about all of those methodological issues and juxtapose that with the common pitfalls that are there in the conduct of the RCT. And this will include concepts related to the common methodological concerns like random sequence generation, allocation, concealment, blinding, analysis, and side by side, I will talk about the consort reporting standards for RCT. So if you happen to be somebody who is doing an RCT for their thesis, or is maybe reading up RCTs to support the clinical research that they are embarking upon, then you would want to know about these reporting standards. And so side by side with the concept, I'm going to be talking about these. And then the latter part of the session, later on, we're going to be talking about some new and upcoming concepts related to RCT, and that's stopping early for benefit and subgroup analysis. So these are topics that are not frequently discussed with regard to conduct of RCT, but they're gaining more and more attention in the world of clinical epidemiology, because these are, again, some very common pitfalls that trialists have to take into consideration. So let me take you back to what we discussed last time when we talked about study design. I had given you an overview of all the kinds of study designs that are there. And we had discussed that if you talk about the two main categories, so the two big categories of types of study design, we classify them in terms of experimental and observational. So experimental designs, of course, are those where the investigator is the one who assigns the exposure. So we are actually administering an intervention here. And within this experiment, there are randomized control trials. And I had mentioned before that the kind of evidence that you generate from an RCT is unparalleled. So when you compare the validity of results from RCT to that from observational studies, you know, the best kind of evidence that you can generate, obviously it's not always possible to do in RCT, but if you can, then the best kind of evidence that you can generate results from a randomized controlled trial. And so we had said that this is something exquisite, you know, it's a beautiful thing in RCT. And it's been written about randomized control trials that the whole of medicine depends on transparent reporting of randomized control trials. And that's probably not an exaggeration, seeing that these studies regularly change practice and they regularly trump the results of observational studies. And nowhere is this more obvious than in the case of COVID, right? So, rightly, Dave Figure and Dr. Kapil just mentioned near the top of the evidence pyramid. So, this is the evidence pyramid where we kind of list study designs by validity of the findings. So, as you go higher up in the pyramid, the risk of bias reduces and the validity increases. And so RCTs are the best kind of primary research out there, and arguably rightly so. So if you talk about the basic design of a randomized controlled trial, it's a very simple design. You have two groups that are generated, the intervention and the control group. And the intervention group is the one where you assign the exposure. So this can be a drug, it can be a device, it can be a public health intervention, it could be a health policy intervention, any intervention that is assigned to this group. And then you follow them up. You follow them up over a period of time to see who has the outcome and who doesn't amongst these two groups of people. Okay. Now, the real beauty of randomization, you can see from here, the concept is similar to a cohort study. So this is what we had seen in a cohort study, that you make two groups and you follow them up and you see who has the outcome and who doesn't. But the real beauty of a randomized controlled trial is how these groups are created. And that is by a process called randomization. And why this is such a beautiful process is because it creates two groups that are prognostically balanced, right? So randomization is a process by which we create these two groups. And this process is conceptually similar to tossing a coin. So conceptually, you can think of it like a participant comes into your trial and you assess eligibility. And if he's eligible, conceptually, you toss a coin, and you have a rule, like if it comes out as head, it goes to intervention. If it comes out as tail, it goes to a certain group. So you have that rule, but conceptually, every participant that enters the trial should have an equal probability of landing up either into the intervention arm or the control arm. It should be an equal probability. And that is why randomization is so beautiful, because these two groups of people that you land up with, intervention and control group, they have the same destiny, right? So they have absolute prognostic balance. You have sufficient numbers, you will gain prognostic balance across these two groups, which means that they will have an equal proportion of males and females, an equal proportion of all age groups, an equal proportion of those with comorbidities, an equal proportion of those that practice yoga or are football fans or engage in physical activity more often. So everything is prognostically balanced among these two groups, so that any difference that you see later on in the outcome, you can attribute to the intervention, right? And so this is the basic design, and we'll talk more about the nuances as we go along. But overall, it's a simple design to create two groups with the help of this process called randomization, which is similar to tossing a coin. And then you follow them up to see who has the outcome and who doesn't. Okay, so the first methodological issue that you have to deal with in an RCT is random sequence generation. And what this deals with is basically when you're making those two groups, the intervention and the control group, you have to use an assignment rule. And you have to make an unpredictable list and assignment rule. So it should be unpredictable in the sense that it's only truly random if nobody can actually predict what will happen. So every participant should have an equal probability of landing up either into intervention or control. And random sequence generation is what ensures that. Now, this can be done by referring to a random number table. And most often now people use computer random number generator. So you have websites and online software that generate a random number table, and Consort says that authors should specify the method of sequence generation, such as random number table or a computerized random number generator. So most often nowadays we use a computer generated random number table. However, this is not always done. So if you see this trial, this was a randomized control trial in status epilepticus in children. So children came with seizures. And this is how the trial is assigned the exposure. They said children were assigned to receive either diazepam or lorazepam on an odd and even date basis. That is, children admitted on an odd date received diazepam, and those on an even date were given lorazepam. So this is not a random sequence. Anything that already determines who is going to get the intervention does not qualify as being wrong, because you've already decided. So every participant does not have an equal probability of either going into diazepam or lorazepam arm. You've already decided because you've done it on an odd and even date basis. And this is done all the time. I see this being done all the time. People often use odd and even admission IDs or patient IDs, odd and even year of birth, odd and even days. So, I mean, any deterministic method that is non-random should not be reported as being random, right? And this is exactly what Concord also says. This is the reporting guideline. They say random is often used inappropriately in literature to describe trials in which non-random deterministic allocation methods were used, such as alternation, hospital numbers, or date of birth. When investigators use such non-random methods, they should describe them precisely and should not use the term random or any variation of it, right? So truly speaking, random sequence generation, you do using a computer-generated random number table, and that's when it's truly unpredictable. Now, to tell you about the next concept, I'm going to tell you a story, and I think it's about time we start the interaction within the session. So I'm going to ask you a question once I'm done telling you the story, and you have to tell me the answer by either unmuting your microphone. You can openly speak whenever you want to, or you can type it into the chat box. Now, this was a true story about a trial that happened in Australia, where they compared laparoscopic appendectomy to open appendectomy, right? So this was the trial. They compared laparoscopic versus open, and they created a very nice sequence for doing randomization. So they had a computer-generated random number sequence, and they generated that sequence and they kept it in sequentially numbered envelopes, right? So they had a series of envelopes that had that sequence, and so whenever a patient of appendicitis or suspected appendicitis would come, they would tear open the next envelope, and if it said laparoscopic, the patient would go to laparoscopic, and if it said open, the patient would go to open appendectomy, right? So they had a beautiful sequence that they had kept in sequentially numbered envelopes, and of course you could not disturb that sequence. They were stuck together, the envelopes, and you would have to open the next one in the sequence. Now, the problem was that in this hospital, the only people who were trained in doing laparoscopic appendectomy were the faculty members, right? So the residents were not trained in doing lap appendectomy. And so, particularly during night time, they would feel really awkward because they would have to call into, they had to call their faculty. And it was an awkward situation because, as you can imagine, faculty wouldn't like being disturbed late at night and having to come and do a lap appendectomy. And it was a very difficult situation for the residents to have to, call them up, and they would come, and probably it was not very pleasant, that encounter. And so they started doing this, right? So whenever a patient would come during the night, they would tear open they would take out the next envelope and they would hold it against the light, right? And if it said laparoscopic appendectomy, they would keep a little behind, right? And they would keep doing this until they reached an envelope that said open appendectomy, right? And this actually happened. Now, my question to you is that because of this, this situation, what happened in this trial, how would this affect the results of the trial? How would the results of the trial be affected? And you can either unmute and talk, or you can put in your answer into the chat box. And I will give you 1 minute to think about it, and then I'll wait for your answer. So everybody understood the question? It was a trial that compared laparoscopic and open appendectomy, and they had sequentially numbered envelopes with the random sequence. And what the residents started to do was that when a patient of suspected appendicitis would come during the night, they would hold the envelope against the light. And if it said open, laparoscopic, they would keep it a little behind so that they don't have to call up their faculty and call them to do the surgery. And that's why I'm asking you, how would this affect the results? So somebody has written selection bias. Yeah, right. I mean, you're absolutely, there is a bias for sure. We haven't spoken about types of biases, but so according to you, which intervention would end up looking better? And people are correctly identifying that there's obviously going to be some sort of a bias, but biased, which intervention would look better because of this mistake? Sorry? I'm sorry, I could not hear what you said. Somebody unmuted. Okay, somebody's written open. Okay, and why would open look better? Why would open look better? So it's clear that most of the patients that came during the night, they got most of the patients that turned up during the night, they got open surgery, open appendectomy. So according to that, so what do you think will happen to seeing a result in terms of outcome? Which one would look better, open or laparoscopic? Yeah, number of sample increases for open, right? But in terms of looking better, which intervention, laparoscopic or open, would start, according to you, would falsely look better, and why? Yeah, residents are better trained in open rather than lap, right? They're not trained in laparoscopic at all, exactly. So which one would look better, open or lap, and why? So let me ask you another question following that. According to you, the kind of patients that turn up during the night, are they more severe or are they less severe usually? Yeah, exactly. So usually patients that turn up during the night are more severe. So that would basically result in the kind of patients that got open appendectomy were more severe patients, right? So now can you tell me which one would look better, laparoscopic or open? Anybody can answer. And I'm so grateful to everybody who's interacting. Anybody? So more severe patients, okay, laparoscopic, right? So thank you. Right, exactly. So the reason that laparoscopic looks better is not because we actually know that it does, but rather because they got to know the sequence. It was not hidden properly, is why the kind of patients that came into the open arm were more severe, right? And although they created a really good sequence, it was not hidden from those that were recruiting the patients. And that is what is the issue when we talk about allocation concealment. So when we talk about allocation concealment, it is basically referring to the random sequence being hidden from the recruiter. So once you've created a really nice sequence, it's not that it should be out there in the open for everybody to see. And basically, the recruiter should not know to which arm the next patient will go to. They should not know. And that is allocation concealment. And in unconcealed trials, a recruiter may systematically enroll sicker or less sick patients to either a treatment or a control group. And this is certainly what happened with this trial. And later they conceded and they wrote about it and they said that's what has happened. And certainly when the allocation is not concealed, then recruiters may actually have their own subjective ideas with regard to sending patients to a particular arm, and that should not happen. So this is the Concord statement on concealment. Trials in which allocation sequence had been inadequately or unclearly concealed yielded larger estimates of treatment effects than the extended trials in which authors reported adequate allocation concealment. And actually, only 18% reported any allocation concealment mechanism. So this is a major lacuna out there with regard to reporting of RCTs. So how do you conceal allocation? Well, you can do it either by not keeping the sequence with you, but rather with a third person who you have to call into. So a remote telephone or web-based system where a third person has the sequence, and you have to call into them, and they are the ones that are not involved with the trial, but they have the sequence. The most robust method now is an interactive voice response system. So this is what most big trials are using now. Certainly all the pharma-sponsored ones and even institute trials. So this is basically like similar to how you call into customer care, and you have that system where you dial, and that's the interactive voice response system. And this is a nice sophisticated system. Or you could use sealed, opaque, sequentially numbered envelopes, and the keyword here is of course opaque. And in a placebo-controlled trial where nobody knows, so a placebo is identical looking, it tastes the same, it looks the same, it smells the same, so nobody knows which is drug and placebo. And so in a placebo-controlled trial, you can't influence allocation. So again, that's another method where automatically allocation concealment happens. So these are all the ways that you can conceal allocation. So let me ask you any questions so far. Right. So somebody's written because faculty more experience. Right. So both ways, faculty more experience and also the kind of patients that turn up during night, both would favor laparoscopic appendectomy. Dr. Navnika wrote difference between randomization, allocation, concealment. Well, when we talk about randomization overall, we talk about these two issues. The first is random sequence generation and the second is allocation concealment. So these two issues are there. And these two issues are the main issues that you have to grapple with when we do randomization. Random sequence generation refers to generating of the sequence. It should be random so that it's not predictable. And that is done typically using a computer-generated random number table. And allocation concealment refers to not knowing to which arm the next patient will go to. So it should be hidden. The sequence, once it is generated, it should be hidden from the recruiter. And so those are the two main issues when we talk about randomization. Okay. So hopefully that clarifies. So this is an example of how a trial reported allocation concealment. They wrote the sequence was concealed from study researchers, and the allocation to treatment groups was obtained by telephone to an interactive voice response system developed at the Robertson Center for Biostatistics, University of Glasgow, right? So whatever. So this is what they have reported, your interactive voice response system developed by so-and-so. Now, if you were to judge whether randomization has taken place properly, one can look at the table 1, which is the baseline characteristics table. And here you can actually see a comparison of the two groups that are created from randomization. So this is a trial on oral cancer having two groups, the chemotherapy and the no chemotherapy group. And you can see that everything's balanced out here because you have similar age, similar proportion of males and females, and tumor stage, etc., etc. And if you're wondering, very often people put a p-value table here in the next column, but Concord discourages it. They say, unfortunately, significant tests of baseline differences are still common. Such hypothesis testing is superfluous and can mislead investigators and their readers. So why? Because what the p-value in the baseline characteristics table is telling you is basically whether any difference between these two groups is by chance or not. But in a randomized controlled trial, any difference that occurs between these two groups has to be by chance. So it's expected that 1 in 20 of those p-values will be less than 0.05 in any case. So that's why it's not necessarily wrong to put a p-value column here, but it's just not very meaningful, and that's why Concord says it's not required and should not be reported. So just one thing that I wanted to mention in passing. Now, allocation concealment is different from blinding. Blinding basically refers to once the randomization has already happened and once you've created those two groups. Now, subsequent to that, different people should not know who is receiving the drug and who is receiving a placebo, right? Or who is receiving what intervention. So that refers to once you've already created the group. And until randomization has happened, until then, we refer to it as allocation concealment. But once it has already happened and those groups are created, after that, different actors are made unaware of the treatment received by participants. They could be health personnel, it could be patients, it could be outcome assessors. There are 5 types of people who can be blinded. I'll tell you in the next slide. And so these are 2 different concepts, right? And the kind of bias prevented is also different. Timing in the trial, allocation concealment is done before the start of treatment, so during allocation, and blinding is done after allocation, so after the start of the treatment. Who is made unaware? In allocation concealment, those recruiting, assessing eligibility, and in blinding, those treating, getting treated, assessing outcomes, adjudicating or analyzing data. So there are 5 types of people who can be blinded. So basically, allocation concealment maintains the sequence until randomization, and beyond that, the sequence is maintained by blinding. Now, this is the concept statement on concealment. The allocation concealment should not be confused with blinding. Without adequate allocation concealment, however, even random, unpredictable assignment sequences can be subverted, and certainly we saw that in the example. Also, very often it's not possible to blind. So, say you are doing a trial like this one, laparoscopic versus open. You can't really do blinding because unless you do a sham open surgery, people will know which intervention you gave. Or if you're comparing medical and surgical, or you're comparing 2 routes of a drug, you can't blind. However, allocation concealment can always be achieved. So regardless of blinding, one can always conceal allocation. So there's no challenge there. Even if you're comparing medical and surgical interventions, you can't do blinding, but you can do allocation concealment. So any questions so far? I can't see the chat box, so Dr. Jispan, just let me know in case anybody types in a question. Okay. So let me give you an example. This was to tell you about blinding. This was a systematic review which we had written on longer versus shorter duration antiplatelet therapy after stent placement. So they had compared all of these trials included in the systematic review. They had compared single versus dual antiplatelet therapy. So 6 months versus 12 months of both aspirin and clopidogrel. And what happened in these trials was that they were all unblinded trials, right? So both the physicians as well as the patients and everybody in the trial, they knew who was getting 6 months of dual antiplatelet and who was getting 12 months of dual antiplatelet. So what happened in these trials was that the patients, because they knew that they are taking only single antiplatelet, they actually went out and bought the other drug after 6 months. So they went out and bought aspirin. And their physicians, they knew that their patient is in a single antiplatelet arm, so they compensated by increasing the dose of aspirin, right? And so this is the problem with unblinded trials, that there's contamination. So that refers to an arm getting an intervention which they were not assigned. So, the patient went out and bought the other drug. That's contamination. And there's co-intervention. So the physician increased the dose of aspirin, and so they gave an added intervention apart from what was meant to be assigned. And blinding actually prevents these 2 things, right? So what is blinding? and what is the blinding is basically making different actors unaware of who is receiving which treatment. And it maintains the benefit of random allocation. So once you've already achieved a prognostic balance amongst those two groups by randomization, there's no guarantee that that prognostic balance will be maintained throughout the trial. But blinding is an attempt to actually ensure that it is maintained, that prognostic balance is maintained throughout the trial. When there is no blinding, then physicians often they administer unequal care to the groups. For example, the patient in the single nanticated arm, they did lifestyle changes and they went out and bought the other drug. And as I have told you, it avoids co-intervention. So these two things are avoided, co-intervention and contamination. Any questions? No, okay. So who is blind? 5 types of people who can be blinded in a trial. The first is the patients themselves. The second is the caregivers. Third is data collectors. Fourth is outcome adjudicators. And the fifth is data analysts, right? And actually, when you talk about a double-blinded study, there was one actual survey that was done by Devereux et al., where they had surveyed 91 physicians in 3 Canadian universities to provide their definition of double-blind. So who is blinded in a double-blinded trial? And then they also did a review of definitions of double-blinding in epidemiology textbooks. So they went out and asked physicians, who do you think is blinded in a double-blinded trial? And they saw textbook definitions to who is blinded in a double-blinded trial. And had I been a part of this survey, I would have probably said that in a double-blinded randomized control trial, it is the physicians and the patients who are blinded. But the result of this trial actually reveals the correct answer, which is nobody knows, right? So even among the physicians, there was no consensus as such. There were 38% who said what I said, patient and caregiver. And there were many others who said, all 4 of these groups, data collectors, adjudicators. 10% said all 5 types of people are blinded. So, and similar discrepancy across the textbook. So there's no consensus as such with regard to definition of double-blind. And that's why this term is actually a little misleading. It's ambiguous. And Concord says the same thing. They said that research shows that these terms are ambiguous, and as such, authors and editors should abandon their use. Instead, authors should explicitly report the blinding status of the people involved for whom blinding may influence the validity of the trial. So just tell us explicitly in your reporting who was blinded, okay? And so just specify clearly so that such ambiguity is avoided. I think there's a question in the chat box. Right. So somebody said, if we perform case crossover design, the same blinding to be followed. Right. So there are different types which I've not mentioned so far. The different types, the different modifications to the simple randomized control trial design that I have described. And the crossover design I've not spoken about yet, but the crossover design is one in which we assign exposure to intervention and control, and then there's a washout period. And then after a certain interval and a washout period, those two arms cross over. So the one that was in intervention goes to control, and the one that was in control goes to intervention. And to answer your question, yes, blinding can be achieved even in a crossover trial. But once again, one should be explicit in reporting who are the groups of people that are blinded. So this reporting guideline applies to crossover trial work. Now, there's also the issue of change in trial outcomes, and this is a very rampant issue now. So if this was a trial on remdesivir, this was the first trial on remdesivir published in the NEJM. This was the trial that brought remdesivir into the picture for COVID-19. It was the American trial. This was preceded by just one more trial, the Chinese trial, which they did not complete because the numbers went down. But what most people did not notice for this trial, although it had a huge impact in terms of translating remdesivir into practice and people started administering it after this trial, they did not notice that the initial primary outcome was changed, right? The primary outcome was changed midway. And so initially their primary outcome was mortality, and they said that the initial primary outcome became the key secondary outcome. And so they changed it to symptom resolution or some similar outcome that was a little different and maybe less clinically important. But so when we had done a systematic review on remdesivir, we had classified this as other biases, because a change in primary outcome kind of raises a red flag. And CONSORT says that authors should report all major changes in the protocol, including unplanned changes to eligibility criteria, interventions, examinations, data collection, methods of analysis, and outcomes. So any changes in the protocol in a trial, they should be reported clearly and explicitly. And that includes all outcomes that were intended to be studied, but then you ended up not studying them, or any outcomes that were intended to be primary outcomes, but we did not report them as primary outcomes. So everything has to be reported as such. Now, to demonstrate the next issue with a randomized control trial, I'm going to tell you about this study, and I'm going to ask you a question right after I tell you about this trial. This is an actual trial that was published in the New England Journal of Medicine. It's a very old trial, but a very famous one. They had compared a cholesterol-lowering drug to placebo. So this was a new statin, and they randomized 4,000 individuals, 2,000 to statin, the cholesterol-lowering drug, and 2,000 to placebo. Now, in the intervention arm, in the cholesterol-lowering drug arm, there were compliers and non-compliers. So 800 compliers, 1,200 non-compliers. And the mortality among the outcome was mortality. The mortality amongst compliers was 15%, and in placebo, the overall mortality was 20.9%. And this difference was very, very statistically significant, so 0.0003. And so this was a pharma-sponsored, industry-sponsored trial. And so industry said, look, if you take the drug, there's 15% mortality. And in placebo arm, there's 20.9% mortality. And this difference is so statistically significant. And therefore, the drug works, right? Drug works. So my question to you is, would you want to know anything more about this trial result, or would you be comfortable administering this statin to your patients? Is there anything else you want to know? And there is $1 million question here. So is there anybody who wants to know anything else? Comorbidities. Right, so comorbidities were there, of course. They were very high-risk patients, you can tell from the mortality. But in a randomized control trial, the comorbidities will be equally distributed. So there's prognostic balance among these two groups. And it was a wonderfully conducted trial, the perfectly conducted trial. They did very good random sequence generation, excellent allocation concealment, excellent follow-up. It's perfect, impeccable. Is there anything else you want to know? So somebody wrote adverse events. Yes, of course, there were adverse events, which is why there are so many non-compliers. But the pharma company said, yeah, there's non-compliers because of some adverse events. But they said, see, if you take it, it works. In compliers, there's 15% mortality. If you take it, if you comply with the treatment, then it works. Is there anything else you want to know? Anything else you want to know? There is $1 million question here. What is that $1 million question? Mortality in non-compliers. Let me tell you, the mortality in non-compliers is 25%. And that is a good question, but it's not the $1 million question. So 25% mortality in non-compliers. Let me access my chat box again. Okay. Right. Somebody said blinding. I told you it is a perfectly conducted trial. It is placebo-controlled trial. It achieves blinding. It's beautifully conducted, perfectly conducted. Time period of mortality. It was soon after administering, but that's not the $1 million question. Compare with gold standard. Not sure what that means, but I think maybe you mean that standard of care. So standard of care was given to both. So again, I mean, I don't see how that affects. Anything else you want to know? Reasons for mortality? Yeah, they were all heart patients, so all coronary artery disease patients. But again, that's not the middle. So what do you want to know in terms of affecting whether you will give the drug or not? I mean, reason for mortality is cardiovascular events. I mean, the 15% in the ones that took the treatment and 20% in placebo. So, and this difference is really significant. And so they said that if you take it, it works. Anything else you want to know? Anything else anybody wants to know? Frequency of administration, yeah. I mean, there was a regimen for this. But what else do you want to know in terms of affecting the validity of this study? Every time I've taught this, somebody or the other has come up with $1 million question. At what stage of disease progression is the drug given? Well, I mean, there is a regimen for this intervention, of course. So there's a dose, there's, of course, there's everything is already given by the pharma company. They've told you, who you should give it to, how you should give it. So again, that is not the $1 million question. Are you happy with this conclusion that if you take the drug, it works? Is everybody comfortable accepting that conclusion? Or is there anything you want to know? Just think about it. Co-interventions. Co-interventions did not affect the trial because it was a placebo-controlled trial. So perfect blinding. So, I mean, the impact of co-interventions was negligible because it was a placebo-controlled trial where they achieved very good blinding in this trial. Anything else? Standard of living. Standard of living, randomization. Randomization happened very well in this trial. So it was a perfectly conducted trial, as I have said. Everybody happy with the conclusion that this drug works? Everybody, no further questions anybody wants to know that this drug works or not? Why non-compliers were included? Well, non-compliers are not included here. You can see that they've compared the mortality in compliers with that in overall placebo. And they've compared the mortality in compliers with overall placebo. And that difference is statistically significant. And that is why they are saying that if you take the drug, then it works. And my question to you is, are you happy with that conclusion? That if you take the drug, it works? Or do you want to know something else? Reasons for non-compliance, there was some adverse event. Of course, there's a major adverse event. But they said if you are able to achieve compliance, then it works. Outcome of disease control or lowering of lipid was evaluated. So they had a standard that was very robust with regard to this lowering of lipid, but the outcome is a very hard outcome. It's mortality. So basically, mortality is a hard outcome in the sense that even if you don't, even if you have an outcome assessment that's not very good, it's not going to affect it because mortality is clearly, it's very easy to measure mortality. There's no bias with regard to measurement of mortality. What if we do not achieve compliance? So if we don't achieve compliance, it's 25% mortality. Anything else? And I'll give you just one more minute to think about it before I'll tell you what the $1 million question is. Unless somebody comes up with it. Okay, let me tell you. Difference in sample size. Well, 2,000 were random. So there were 2,000 in each arm. I mean, 4,000 people were randomized. There were 2,000 in each arm. So, well, let me just tell you now. if you look at the placebo arm in this trial, even in the placebo arm, there are compliers and non-compliers, even in placebo arm. And even in the placebo arm, the difference in mortality of compliers and non-compliers is huge. So there's 15% mortality in compliers in the placebo arm, and 25% mortality in non-compliers in the placebo arm. And if you're a person who gets impressed by small p-values, just look at this p-value, 4.7 into 10 raised to the power minus 16. So the mortality difference amongst compliers and non-compliers in the placebo arm is very, very, very statistically significant. And if you look at the overall mortality between these two arms, intervention and control, you can see that there's actually no difference. So 21% mortality overall in intervention arm, and 20% mortality overall in the placebo arm. And this is not statistically significant, of course, which tells you that even in the placebo arm, compliers do better than non-compliers, which tells you that compliance itself is a prognostic factor, in the sense that people who comply with the intervention to which they are assigned, they also comply with other lifestyle interventions, like they are also more compliant to antihypertensives, or they're also more compliant to lifestyle interventions like good diet and exercise. And so it's not correct to only take compliers into your analysis, because if you only take compliers, what you're taking out of your analysis is a group of people that are prognostically very different from the rest, right? And you went through all the trouble to randomize to create two groups that are prognostically balanced. So I told you, that these two groups of people that are created from randomization, they have the same destiny. So they are prognostically balanced. And you went through all the trouble to create this prognostic balance by doing randomization. And then you throw away that advantage. You throw it away. Why? By just taking compliers into your analysis. And you can't do that, because you have lost the prognostic balance that randomization created in the first place, right? And that is what is referred to as intention to treat analysis. It refers to all patients being analyzed, keeping them into the group to which they were randomized. And the short phrase for this is once randomized, always analyzed. And the main reason for doing intention to treat analysis is to maintain the prognostic balance that randomization created. Okay, that is the main reason to do intention to treat. In a crossover, in some trials where patients don't get the intervention to which they are assigned, so in the case of where they cross over to the other intervention, there's another reason that people give, that this is more representative of the real world scenario. But the main reason, certainly in most trials, is that we want to maintain the prognostic balance. And so these two groups are prognostically balanced, 2000 and 2000. And so we have to analyze them as such in order to maintain the prognostic balance, right? And so CONSORT says information about whether investigators included in the analysis all participants who underwent randomization in the groups to which they were originally allocated is of particular importance. And now there are different variations that trialists are using, getting modified intention to treat, etc., etc. So basically, to ensure transparency, CONSORT just says, tell us who was analyzed. So just give us the numbers, how many were randomized, how many were analyzed, and that is how they represent it in that CONSORT diagram. So reporting intention to treat is generally favored because it avoids bias associated with non-random loss of participants. Regardless of whether authors use the term intention to treat, they should make clear which and how many participants were included in each analysis. And that's what I was talking about. And certainly with regard to compliance, this is an important issue, because non-compliers, if you take out of your analysis, then what you've done is that you've lost that prognostic balance that randomization. Now, the last concept I'm going to talk about is an important one that's gaining more and more dialogue in medical literature. And to tell you about that, let me tell you about this trial. It was a trial in acute myeloid leukemia, where they compared 5 versus 4 courses of chemotherapy. So one of the arms got 5 courses of chemotherapy and the other got 4. And the outcome was mortality. And so these trialists, they started out, of course, doing the trial, and you can see in the beginning, this is inconclusive, it's a very wide confidence interval. But as they enrolled more and more patients, you can see that there was an indication that 5 courses of chemotherapy is better at reducing mortality. And certainly by, these many patients, 41 events and 66 events respectively, they achieved their stopping boundary, and they saw that it was a very big effect. So 45% reduction in mortality with 5 courses of chemotherapy was 4. But the trialists thought, you know what, this is probably too good to be true. So they didn't stop here. They continued to enroll patients into their trial. And you can see as they enrolled more and more patients into their trial, you can see that that mortality benefit is actually lost. And in fact, towards the end of their trial, where they had accrued a lot of events into their trial, you can see that there's actually an indication that 5 courses may actually be harmful. Now, this is important because had they stopped right here, when they had 41 events and 66 events, then, this result would have resulted in so many patients getting an extra course of chemotherapy with so many adverse events, when actually there was actually no mortality benefit from that extra course of chemotherapy. And this happens in trials all the time, that when you have a few number of events in your trial with small sample sizes, then there's usually an overestimate. So there's a false indication of a positive effect with few events and a small sample size. And let me tell you why this happens. To understand why this happens, let's consider some trials that are studying a true beneficial effect that is actually a small effect. So this line is indicating the true beneficial effect, which is in actuality a small benefit. Now, some trials will actually start out and they'll remain close to this true beneficial effect throughout, right? So they'll more or less remain along these lines with regard to detecting a benefit. Now, if these are all methodologically well-conducted trials, and there's no bias as such, then just by chance alone, random error, some trials in the beginning will show a harm, but as more and more events accrue, they will arrive at the truth, which is the true beneficial effect. Similarly, due to random chance alone, some trials will, in the beginning, when there are few events, they will show a benefit, a very large benefit. But then again, as more and more events accrue, they will arrive at the truth, which is the true beneficial effect. And Pocock, the statistician Pocock, he describes this very beautifully. He called it regression to the truth. This is regression to the truth. That as you enroll more and more and more and more people into your trial, and more events accrue, that is when you start arriving at the true effect, which is most likely a true beneficial effect. But if you stop early, so say you stopped here, then there's actually a chance that you may have caught your trial at a place where it's at a random upswing, right? So the chance of making a false positive conclusion is very high early on in the trial, where there are few events and very small sample size, which is why very often small trials, they show a very large benefit. But as you accumulate more and more events into your trial, that benefit is lost, as you saw in that first example I gave you. This is also why multiple interim analyses is very dangerous, right? Because if you keep looking at the data again and again and again and again, then there's a chance that you will make a false positive conclusion, because you may catch the trial at a place where it is at a random upswing of that result. And that's why interim analyses are infamous in epidemiology. Whenever you do an interim analysis, it has to be overlooked by a statistical committee that avoids the chance of making a false positive conclusion. So there are many mechanisms in place in statistics, in epidemiology, that make it difficult to draw a conclusion from an interim analysis. Because if you keep looking at the data again and again and again, there's a chance that what you're finding there is actually just by random error. Right, so this is what CONSORT has to say about interim analyses and stopping rules. Reporting of timing of interim analyses, you have to report all of this. What triggered them, how many took place, whether these were planned or ad hoc, and whether there were statistical guidelines and stopping rules in place take priority. And certainly, this is a major issue when we were talking about COVID trials, the Paxlovid trials, where there were very few events. And that's why people wrote about it. They said that, can you really rely on the results of these trials because they have such few events, and we need to accrue more events in order to really conclude correctly. And this information is often not included in published trial reports, even in trials that report stopping earlier than planned. So the next topic was subgroup effects, which I probably think I should stop short here because I've completed my 60 minutes. And I think I will defer to Dr. Jaswant about whether we should start the interactive session and the question and answer session for the participants, and maybe I can take up subgroup effects in the next session or in the last session where we have some topics on demand. And so, Dr. Jaswant, should we start the interactive poll for participants and see if they have any questions with regard to whatever has been taught so far? Dr. Jaswant, are you there? Okay, I think Dr. Ravi, Mr. Ravi, could you start the interactive poll for the participants for the interactive session? You will have a series of question and answers, the true and false assertions. So you have to answer true or false for all of these assertions, right? And there are 8 assertions there, and just vote true or false for all of these assertions, and we will end the poll as soon as a sufficient proportion of participants have answered. Okay, I think Mr. Ravi, most people have answered. I can see that more than 70%, or 70% people have
Okay,
answered.
so I close it.
I think, yeah, I think we can close the
Okay, I just end.
poll and let's discuss. Yeah.
This is the
Okay.
result.
Okay, great. All right. So let's just discuss. And again, please feel free to unmute your microphone and speak up whenever you feel like you have another question related to this, or you want to make a suggestion or a comment. So the first assertion was a study can only be an experiment if it has random allocation of exposure. And correctly, so 63% people said false, and you were right, this is false. We had spoken about experimental designs in terms of both randomized and non-randomized studies. In fact, there are something called quasi-experimental studies also. So those that are like pre-post, etc. Or they can just be non-random allocation of exposure. So very often we don't randomize. Of course, in terms of validity of findings, they're not as good as randomized control trials, because randomization achieves that prognostic balance so that we can attribute effects of interventions to a given intervention. So, of course, a randomized control trials are superior, but they're not the only kind of experiment. So correctly, most people identified that the statement is false. Any questions related to this? Okay. Randomization in a trial always false confounding. Now, most people said true, and it may seem intuitively like a true thing, but what if I told you that there's a trial where we randomize 10 participants, and in one, it's possible that if you randomize 10 participants, you may land up with 3 and 7, those numbers in either arm. So although randomization does solve confounding, but you need sufficient numbers for randomization to work out that way. So you do need a sufficient number in terms of sample size, so that you can be certain that randomization has achieved that prognostic balance, and it has in fact avoided confounding. If you have very few numbers, then it's probably not going to work. So certainly with 10 or 20 or 50, it may not work. Any questions? Okay. A randomized controlled trial is a follow-up study, either prospective or retrospective. And for this, 69% said false and 31% true. And I would have given you an example of a retrospective RCT, if it existed, but it does not exist. So, of course, the statement is false, correct. You're absolutely correct, most of you. Because RCT, we are administering the intervention and following up. And so all RCTs are prospective studies. In fact, you can think of them as a special type of prospective cohort study where we are the ones assigning the interventions. All RCTs are prospective. A randomized controlled trial is a design of choice that studies of treatment efficacy, and correctly, most people, in fact, more than 90% people said true. And yes, this statement is true, correct. And certainly in terms of giving evidence, the validity that an RCT yields for any given treatment or intervention is way superior than observational studies or non-randomized trials. And in fact, most interventions, any drug or vaccine that has to come into the market has to go through that process of multiple randomized control trials. Next, the objective of randomization is to achieve comparability at baseline. And the statement is true, and most of you said true. So you are right. Yes, the objective of randomization is to achieve that prognostic balance and to achieve comparability of baseline characteristics. And of course, the mechanisms that maintain that prognostic balance are other things like blinding, right? So blinding tries to maintain that prognostic balance that randomization achieves. But at baseline, to achieve prognostic balance, we have randomized. The credible analysis, that does the next assertion, the credible analysis in a superiority trial is an intention to treat analysis. And we just spoke about this with regard to that trial I told you about, the statin lowering or the cholesterol lowering drug. And so correct, this statement is true that for a superiority trial, intention to treat is the credible analysis. If you ask me, is it always the credible analysis in all kinds of trials? No. There is a particular kind of trial called a non-inferiority trial. Again, we need to dedicate a complete session to non-inferiority trials if you want to know about them, because they are gaining so much popularity now, but they have special interpretational challenges. So they have special issues that you have to know about in order to interpret results from non-inferiority trials. And in a non-inferiority trial, intention to treat may mislead. So it actually may be a non-conservative analysis. So intention to treat in terms of a superiority trial is a conservative analysis, which means that it's more difficult to show the efficacy of an intervention with intention to treat. Why? Because we're taking all patients into the denominator. So it's more difficult to capture, to detect that signal, because we're taking everybody into the analysis. Whereas in a poor protocol, which is the opposite of intention to treat, it's easier to show an effect. But in a non-inferiority trial, an intention to treat analysis can be anti-conservative. So it may actually be less conservative. So in a non-inferiority trial, we must do both. So both intention to treat and poor protocol. Okay. Any questions? Any questions? No. Okay. In a trial of surgical versus conservative management of polycystitis, it is possible to achieve blinding and allocation concealment. A very close call with regard to answers here, almost 50-50. So I have told you that allocation concealment refers to not knowing to which arm the next patient will go to, whereas blinding refers to the process after randomization has happened, after the groups are created, not knowing which intervention which patient is getting. So in surgical versus conservative, of course, it's not possible to blind unless we do sham surgery in the conservative arm, but it's always possible to achieve allocation concealment. So allocation concealment can be achieved regardless of blinding. It can always be done. Right? So even when we're comparing surgical, medical, or different routes, etc., you can always do allocation concealment. So it's not impossible to achieve allocation concealment. So the statement is false. Randomization reduces confounding from known and unknown confounders. And oh my God, 100% of people got correct. So I don't think I need to discuss this, and the statement is true. Right? Okay. So thank you very much for your interaction. We now have the question and answer session. So you can please unmute your microphone if you have any questions, or you can type in your questions into the chat box. Any questions with regard to randomized control trial, or with regard to the previous session of study design, something that may have been bothering you from the previous session that we had, or the present concepts that were discussed? Any questions that you may have with regard to designing your thesis if you're maybe doing a randomized control trial? You can please ask before we wrap up the session. So I'll give you a couple of minutes to think, maybe 30 seconds maybe to think about any questions. Otherwise, we can close the session. Okay, I think there are no more questions. So, Dr. Jaswant or Mr. Ravi, if you're there, how do you think? Do you think we should move on with wrapping up the session?
Yes, ma'am.
So
Okay.
yeah, so thank you very much, Dr. Manya Prasad, for the wonderful session. So now I would like to invite Professor Ajay Sood, sir, for the vote of thanks.
Thank you, Dr. Jaswant and Dr. Manya. I think the session, you have a very complex issue which we have made very simple for the students, especially those students who are working in the clinical specialty. I think this session is, I think, very useful, and the key point which Dr. Manya has shared with you will be helpful to you. I again want to make a request because we have deliberately extended the duration to 2 hours so that we can answer your question. So once again, I will appeal to all the participants, especially our junior resident and MD students, that they should ask questions, and even any difficulty they are facing regarding their thesis. Okay, you can always send us those question queries, your problems, your issues. You can send well in advance so that we can put to the speaker during the session. So please remember, this is your program, so kindly participate. So far, we have registered nearly 250 students, but I request that more students should join, more participants should join this session. These are for you. We make a lot of efforts for organizing this session, and our speakers, again, they make a lot of efforts, and they are eminent personalities in their respective areas. Another point I want to highlight is that the next session, which is on Saturday, so still you have nearly 2 days with you. So if you have any questions related to the observation studies, which is a title for the next lecture session, you can always send us by email, and we'll put it to Dr. Manya so that these queries can be taken care of during that particular session. So thank you so much for joining us. And once again, as our secretary, appeal to you that please convey this information to your colleagues, your fellow resident, to join this lecture series, which is basically meant for all of you, to help you for your thesis work, and subsequently the other theme session will help you in your clinical practice. So with these words, once again, I thank the speaker for this evening, Dr. Manya, for making a very complex issue so simple with example. And the key point which she has given, I think, will be very, very useful for all of us, especially our MD student. Special thanks to Dr. Jaswant for moderating this session. So thanks once again for all who have joined. Thank you very much.
Yeah, thank you very much.
Thank you.
Yeah, so my special thanks to Dr. Manya Prasad for making this for all the participants, and thanks to Sood sir. So with this, now we would like to end this session, and thank you all the participants for the active participation during the session. Thank you very much.